Good afternoon, everyone, once again. Thank you for joining this virtual briefing on learning from Nigeria's temporary progress in malaria subnational tailoring. My name is Solomon Oladimeji. I work in Nigeria and I'm going to be facilitating this virtual brief. And I promise you to be a very exciting virtual brief, as we are going to be talking about how Nigeria has been an exemplar in implementing the malaria subnational tailoring and how we can take these learnings and implement it even beyond the malaria space. So as we're about to commence, I'm going to be inviting the managing director of Nigeria Health Watch, Vivian Iekwazu, for welcome and introductions. Over to you, Vivian. Thank you.
Thank you very much, Solomon, for the welcome introductions, and apologies for lateness of this virtual briefing starting. We had expected somebody from NEP to join, but she's unavailable, so we'll start. But yes, as Solomon mentioned, we're really pleased today to be sharing with you the findings from the SNT tailoring. So good afternoon, everybody. Pleasure to have all of you here. Good afternoon to development partners, to colleagues, and all those across the malaria community. Especially, I can see some of our media partners on this briefing. So really pleasure to have you here. My name is Vivian Hekwazu, and I'm the Managing Director of Nigeria Health Watch, a health advocacy and communications organization, for those who may not be familiar with us. Really thank you for joining us today for this briefing as we share our research and Nigeria's experience with malaria subnational, or SNT, as you will hear it mentioned. We really aim this really to be an afternoon where we share some of the work we've done. And as all of you are aware, malaria has and continues to be a health concern in Nigeria. We all know the figures, the stats on several occasions. As we know, Nigeria carries one of the highest burdens of malaria in the world. Recent WHO figures continue to confirm this and reflect this. As a country, Nigeria accounts for about a quarter of global malaria cases and about 30% of malaria deaths. And I'm sure every single one of us on this briefing will relate to an experience of having had malaria at some point. I myself remember several times as a child, for example, especially when we visited our grandparents' village, either myself or one of my siblings would often come back with malaria, and it was never pleasant. And I can imagine, and I know as a parent myself now, how concerning it was. So really, more than anything, this is a reminder to all of us why faster progress on malaria elimination is very critical. And children especially are particularly vulnerable to malaria. And in 2024, children in Nigeria, Nigeria alone accounted for about 38% of all malaria deaths globally amongst children under 5. And when you juxtapose this against the fact that as a country, we have a very high birth cohort, approximately 7 million children are born every year. And so the scale of the challenge is even more clear. And at the same time, as a rising population and high birth cohorts, global development assistance, the environment has changed. We all see this happening in real time. USAID shutting down. Last year, Global Fund's eighth replenishment, which aims to raise at least $18 billion, eventually secured about $12.64 billion, with Nigeria, pleasantly surprised, pledged about $15 million. Probably, actually it is, the largest pledge by any African country. And this shows to an extent potential greater country ownership. So at least that's good news for all of us as a country, showing our country is committed to malaria elimination. So this is what really brings us all here today. We are seeing development assistance becoming even more constrained, which makes it even more important that the very limited resources that we do have available are used efficiently. And this really is where subnational tailoring fits in really neatly. So SNT, or subnational tailoring, as I referenced, basically in simple terms means how are we using local data to make local decisions? Because what it does, it recognizes that the malaria burden, the malaria pattern across the whole country is not the same. Transmission differs by geography, differs by season, and how effective each of these interventions are varies according to the local context. So subnational tailoring, or SNT, really brings the information together to help determine which combination of interventions is most appropriate for the particular place that the malaria happens in. So instead of applying the same uniform package, the same interventions across the whole country, we have to say, and we have to use the data to really guide what does the evidence tell us about the particular state, about the particular government, local government area, or the population. So what SNT does, it helps make these choices and decisions even more carefully considered and more deliberate. And as I said, this matters even more now when you have restricted funding, when you don't have as much funding, data to guide decision-making becomes even more valuable and even more important. So when we talk about why we even did this, from the very SNT Exemplar. So the other countries were Burkina Faso, Mozambique, Tanzania, and Laos. And so the exemplars in global health approach really starts from a very practical and simple idea. When some countries achieve minimal progress, despite any circumstances, we need to understand what did they do differently, what did they do well, what worked, and what can others, more importantly, learn from their experience, and how can this be adapted to their settings. So, the Exemplars has done this in other areas such as sexual reproductive health. They've done it in maternal health, looking at how countries were able to reduce maternal mortality. So Exemplars in global health with the SNT tailoring was just another example of how they really looked at how countries were able to reduce their malaria burden. And Nigeria specifically was also chosen amongst the other countries I mentioned because it was noted that the malaria parasite prevalence declined from 27% in 2015 to just 15% in 2025. So in terms of when you say parasitic prevalence, what really tells us is what proportion of young children tested in a national survey were found to have malaria parasites in their blood, in simple terms. So what decline means is that the share of children who tested positive for malaria has fallen substantially. And that's good news because ultimately, as I said earlier, children remain particularly vulnerable as well as pregnant women to malaria. And we do use quite a lot of progress. As a country, Nigeria did make some important evidence-based decisions, and through that approach, we're able to reduce the malaria parasite prevalence, which is, again, as I said, good news, despite having the large malaria burden. And so the purpose really of the briefing today, more than anything, is for us to share what we learned from Nigeria's experience in a way that really goes beyond just, the research that we carried out. So we carried out this research in 2025 last year. So what we want to really do is build a much clearer understanding of what subnational tailoring really is and why it matters for Nigeria's malaria response. And we also want to share the findings and recommendations from the research, including, what did help Nigeria put SNT in place, where were the challenges, where do challenges still remain, and how can we strengthen this approach, especially given the cuts we see in overseas development assistance. So importantly, we want this discussion to really connect the research to the decisions that were made, look at malaria financing and implementation. And for all of you who are working at the state level, we hope that, the discussion today also speaks to some of the realities that you face on the ground. Some of those realities are how do you now translate your national strategies into, decisions that really reflect the malaria patterns and what is needed. For our colleagues in the media, who I see quite a few, we always say the media is the third realm of the state. We hope that the research provides some useful evidence and some storylines as well, just to guide you in how do you report on malaria beyond just looking at the numbers. World Mosquito Day is on Thursday, 20th of August. So this really is an opportunity of how we can discuss not just the high malaria burden in the country, but what the country is learning about how to respond more effectively. So as I said, this is the reason for sharing our experience with you. The purpose of identifying why it was an exemplar and what progress this actually shows. So to just give you a brief, overview of what today will be like, my colleague, Dr. Adachi Ake, Director of Strategy and New Business, will take us through some of the findings from the SNT research in a lot more detail. I've kind of given a very brief overview, including the findings, how evidence is informing interventions, the choices that the country made in resource allocations, and really the lessons and recommendations from Nigeria's experience. And in addition to the presentation that Adachi will share, we want this to also be quite an interactive session. So we invite you to, interrogate some of the questions that you may have in your head about malaria, identify where the lessons from the research can really help inform, whatever the next phase of Nigeria's malaria response. And also really just to ask questions that you yourself may feel you need to, and just to better understand some of the findings from the SNT, because, whilst we did the research, we've done the research brief, which I think was shared with all of you. So you would have had some time to look through it. Really the value of this work lies how better evidence can lead to better choices and better decision-making. Because ultimately, fewer malaria infections, as we know, means fewer deaths. And we know, I'm sure all of us have experienced, malaria recently or in the past, and what that means, you work, so loss of productivity amongst work. So really looking to eliminate malaria is very important. As as a country, we share one of the largest burdens. So really, that is the context for today's briefing. Thank you once again to all of you who have joined today. I look forward to the engagements and I look forward to hearing some of the questions that you may have about the research that we've done. So on that, I will pass you back to Solomon as he takes us to the next part of this virtual briefing. Thank you and over.
Yeah, thank you very much, Vivian, for the welcome and introductions. And you really touch base on everything that we are going to be discussing during this virtual briefing, which basically is about how Nigeria is an exemplar in malaria subnational tailoring implementation and how we can share this lesson. Also, how Nigeria is part of the 5 countries that was selected for this research. Thank you very much. Now I'll be inviting Dr. Adachi Eke, the Director of Strategy and New Business, Nigeria Health Watch, who will be taking us on a presentation based on the topic of this virtual briefing, which is learning from Nigeria exemplary progress in malaria subnational tailoring. She will be taking us through understanding subnational tailoring and why Nigeria adopted an approach of subnational tailoring, as well as the key findings and the promising practices from the Nigerian experience, and how we can use data and evidence to inform intervention choices. And just like Vivian has mentioned, SNT is mainly about using local data for local decisions. So Adachi will be taking us through all of these, as well as the remaining barriers to sustaining SNT in Nigeria and key recommendations and lessons for Nigeria and other malaria endemic countries. So I invite to you, Dr. Adachi Eke, the Director, Strategy and New Business, Nigeria Health Watch, for our presentation. Thank you.
Thank you, Solomon. Good afternoon, everyone. Thank you for your introduction. So I will get right into it. Vivian has spoken really well on what subnational tailoring means, which is basically it's a tool that can be used to make decisions based on data. So if you don't mind sharing the slides and we can get right into it. Thank you. Okay, so the research was conducted in 5 countries, 5 countries who have done really well and have used SNT. That SNT literally means subnational tailoring, who have used it really well. And we wanted to learn what and how and what can be done from how they have used it in the past. So next slide, please. Next slide. So while the slide is coming up, the countries that implemented this research, we looked at 4 countries in Africa: Tanzania, Burkina Faso, Mozambique, and Nigeria, who were classified as high burden, high impact. And then we looked at Laos, which Laos is in Asia, who is at elimination stage. So basically, we wanted to examine what were the barriers and the facilitators to planning, implementing, and sustaining SNT malaria interventions. And we wanted to also learn from the positive outliers of implementation of SNT. So SNT had been implemented in over 40 countries. 5 of these countries did really well, and Nigeria was one of them. So in order to learn, we wanted to see what were the processes that each country took to operationalize SNT. And then what were the best practices? How did the key decisions, how were they made? How can we this about? And next slide, please. For us to conduct this research, we looked at Nigeria as a whole. And looking at Nigeria, we looked at how Nigeria had been implementing SNT. This slide looks at the framework. So what you see, the sorry, if you can go back, is the framework of SNT and is divided into 3 phases. How do you gather the data? You mind going back to the previous slide, please? So how do you gather the data? That's what we call generating the evidence. How do we use the evidence, and what will the evidence that we found? So those are the 3 main parts of the SNT process. You first gather the data, then you try to understand data, and then how do you use it? How do you act on the data? So we have done some quantitative analysis, looking at all the previous data that the country had gathered over the years since they also done some interviews states, where 6 articles also even look at how the use of the SNT was done. We had interviewed different stakeholders of the government. So we looked at stakeholders at the Federal Ministry of Health, the NNP, that's the coordinating malaria body at the national level. Had also looked at the national level, at the state level also. And then we had looked at different donors and funders from the Global Fund, former PMI for PMI stands for the Presidential Malaria Initiative. So after the Trump cuts, we didn't have PMI in Nigeria anymore, but there were still some people or some organizations who were sub-grantees and could give us some insights into those. Then we looked at the different technical supports, the WHO, the different partners who always support the National Malaria Program. And then we looked at the implementers, and these were the different organizations that work currently in the malaria space and had been a part of the NSNC process one way or the other. And so that was how we looked at, that's how we got a lot of insights by interviewing a lot of these different representatives from these different organizations. Next slide, please. Or 2 slides now, because I've talked about the methodology where we did both the analysis, quantitative analysis, looking at data, and then we did key interviews. The process mapping and the stakeholder mapping was what I discussed earlier. Next slide. And so we worked in 6 states, or we went to interview in 6 states according to the 6 geopolitical zones, which were in the northeast, we went to Borno State. In the northwest, we went to Katsina State, and the north central, we had looked at Kwara State. In the south, we looked at Akwa Ibom. In the southeast, we went to Imo State. And in the southwest, we went to Ekiti State. So these were the different states we looked at per political zone on how they also implemented their interventions based on the decisions that were made and what were the challenges on ground. And I know that some of the participants in the in this virtual briefing were some of the people that we had also met in the States. So in looking at the SNT journey for Nigeria, we had looked at what are the milestones since 2015, and we have because first that's like the Bible. That's what we go by. So, first strategic plan, this was in 2015. Nigeria was still using a one-size-fits-all. This is obviously a one-size-fits-all, a uniform approach. But to the burden of malaria, malaria is not just decided by one factor. There are multiple factors. You look at your environment, you look at the vector. What's the vector pattern? The vector as a mosquito. And then you look at the climate, you look at the health system, and then you look at people. So if you think about these different factors, climate, for example, if you don't mind switching the slides to the slide on the SNT journey that had the milestones. Thank you. So when you look at our climate, you can imagine how hot it is in the north compared to how it is in the south. In the north, we have, the raining season is not as much as how it is in the south. If you look at Bielsa, for example. So with Nigeria being a high burden country, the WHO in 2015 adopts that global strategy, and Nigeria aligned with that strategy. And so by between 2015, we continued to have really high burden, and Nigeria was asking how else can they do something better? How else can they reduce the burden of malaria and reduce the death occurring because of malaria without changing so much? So with that, SNT was introduced in 2019, and that was the very first phase. Nigeria has gone through 3 phases now. And so the first cycle, where we probe the data, we try to understand it, and then we now try to act on it. And in 2019 was the first cycle. In 2021, that's when the second cycle occurred. And then the last cycle is what we are currently in. After 2021, the last cycle is what we're currently in, which started in 2024, just before the last malaria strategic plan was done or was developed in 2025. And so this is just how malaria has evolved in Nigeria. These are just key milestones, and I would explain further as we go along. Next slide, please. So before 2019, we had a one-size-fits-all. So whatever was happening in Borno was the same thing that was happening, but then there were so many different factors affecting everything. And so in looking at that, and then a lot of the things that was looked at in Nigeria was also, funding. Funding was a major factor. How do you prevent malaria if you don't have enough funds to go around and prevent it? So funding was a huge factor. We've talked about climate, we've talked about the vector, which is the mosquito and its behavior. We've also talked about the people, and we've talked about the health system. And so with NMEP leading the charge, we decided to ask, how do we use this SNT? Should we do it at state level? Should we do it at LGA level? How SMC literally means seasonal malaria chemo prevention. So that's when they go around in the communities, and people in the communities are given Fancida, sulfadoxine, pyrimethamine. They give them and I don't know if some of you have experienced this, they give these drugs to everyone who are in the endemic areas. So when this SMC was being given, before the SNT, it was being given in 12 states. And it's being given in 12 states, it was, but when they looked at the data, they now found out that it can be over 21 states, about 21 states should now be given. So you can imagine that 9 states were not being given. Sorry, it moved from 9 states to 21 states. So 12 states who were eligible were not being given. And this was what the data helped us inform. And then there was a strong push for how do we control the mosquitoes' behavior, the vector, how do we control the vector in the urban areas? Because you would realize that most people who live in the urban areas tend to know a bit more about how to prevent malaria. So most of them in their houses, they have mosquito nets already at their windows. Most times they have know that they're supposed to clear their environment to some extent, compared to the rural areas where a lot of the homes don't even have, mosquito nets and their windows. They live is more rural, so you have a lot of trees, a lot of trees, and then even the environment is not being cleared regularly, the type of water, keeping stagnant water around. So these were part of the decisions that were taken then, that since a lot of people understood it more at the urban areas, let's concentrate more at the rural areas. And these were how the decisions were being made. And then they were also thinking, should we expand more community healthcare workers? These were questions they were asking as far back as 2019. Then they saw that when they did a geographic analysis, that the community health care workers were actually there, but because they had seen that most people live around 5 kilometers of a health facility, so that was not a priority. And that's what SNT helps you to do. The SNT is not just saying this is what is best for this area, but what should you prioritize also in terms of how much money you have. So when you look at this is what is best for me in this area, or let me give an example. It's just like making a cloth. A tailor makes a cloth for someone. It's not the same size for everybody. A man would not wear a skirt, except maybe you're from Scotland, but you don't expect in our community, you don't expect, a male to wear a skirt, for example. And so if a man can't wear a skirt and you can't give him what he does not need as a tailor if he comes to the tailor. So this is exactly the same thing with the subnational tailoring. How do we ensure that what is needed is what is given? But also, in all the things that you need, how much money do you have to cater for it? And so these were how the different decisions were made at the national. And when these were made at the national, then they invited the states, the subnational, to also validate it. And that's how it was done. So in the first cycle, in the first phase of the SNT, some of the enablers were advocacy and coordination by the NMEP. There were the types of questions that were asked, and then the type of data that was synthesized, the large volumes of data, and how they also collaborate with different partners. And lastly, they used a lot of the spatial analysis to also verify and validate that what they are seeing, the data they get, is actually a true reflection of what is happening in that geography. Next slide. And if you have any questions, please, you can put it in the chat box or note your questions. I'll be able to answer your questions at the end. And so I had basically explained this. This slide is just showing the first map is showing what was being used, before the different interventions that were being used before SNT started. So CM means case management. So when a case comes into the clinic, they would manage as usual. They were using IPTs, that's preventive treatment, which was given to pregnant women. They were using the long-lasting insecticide treated nets. And they were using this across, this was how it was being used in the first map. But then the second map in the middle, the second map shows when they did the SNT, these were now what was ideal. This was what the SNT said will be best to reduce the malaria burden in Nigeria. But the third map now showed where the trade-off happened. At this point, how much money do we have? Do we have all the money as a country to do all of this really well? And so that's meant that we have to make sure the amount of money we have, what could we trade off? So there's something, there's some where we put of these interventions and see what gave the most impact. And that's how they came about for the next strategic plan. That's how they came about all the different interventions. And you can see it's clearly different from what it was during before SNT started, at this first map. So you can clearly see that it was different. So with this, there was that collaborative participation between the donors. So the donors who also supported the country and gave us funds. There was also that participation there were trade-offs that had to be made. And then there was that consensus on the national goal. What do we need to achieve what we're doing? And then they use a modeling that I mentioned earlier to project the impact of some of these decisions that they were making. Next slide, please. Okay, thank you. So now that was the end of the first cycle of the SNT. And by then, after the first cycle, the overall prevalence rate for malaria had reduced. So initially, before SNT, we were at 27%. And so after the first cycle, it had reduced to 22%. And so it being reduced to 22% gave us hope in Nigeria as to, oh, wow, this is really good and we can continue. And so with the phase two, they wanted to improve on what was done. And in looking at it, they then looked at how do we have one source where we can analyze all our data and keep our data. So an electronic integrated data information system, the National Malaria Data Repository, was then launched in 2021. And after that, they had this annual 1 week data deep dive. So everybody will bring their data and then we would analyze together. So this was done in phase two. That was never done in phase one. So they wanted to improve on it. That way, everybody's data is being housed well and then it's being analyzed well. But then another thing they did was they also trained both the federal, the state, and some LGA staff on how to use this data repository, how to go there, how to check your data. And so this data improvement or quality improvement plan was really enhanced in phase two, and that led to a lot of success. So once some of the enablers were the integrated malaria data repository that was launched, there was also the consensus on how data was also being shared, how data passed from, the local government to the state, to the national and all of that, and passed also downwards. And then there was that capacity that was built at the federal, the state, and the local government on how to use the data. And then there was open forum. So if someone brings up their data in the state, the NMEP was ready. There was that open data forum for them to query the data, understand it better, make it, if they're collecting the data wrongly, help them correct it right. So all of these were introduced in the phase two of the SNT, and that led to new malaria interventions. So in the end, they had also revised their strategy. And so when looking at this slide, the first map, when they had looked at it, showed these were all the intervention mixes that the second cycle of the SNT brought. But then again, when there is available funding, you also have to make trade-offs. We don't have all the money to support all the things we want to do. So where do we make those trade-offs? And that's why you have the difference in the map. And what these now led to all the different types of interventions. So somebody that may used to, it's fine, you can keep the slide. So somebody who used to get insecticide treated nets now doesn't need it anymore. And the person may not need it, that state or that local government may not need it anymore. So these were some of the trade-offs that happened in the second cycle of the SNT. So next slide. So things like indoor residual spraying, the ITNUs, all of those changed. So now in the phase 3, when we had our new administration coming in 2023, and we were about to start the next cycle because the malaria strategic. So you start planning before then to ensure that it is ready so that once the last strategic plan is ending, the next one, you're not now starting a new strategic plan. So very proactive approach by the MEP and the Federal Ministry of Health. So based on what happened, I mean, we all know about the funding cuts. And there was a lot of funding cuts also coming up. So we have grant cycles that are being given by the Global Fund. And based on the grant cycle and the new leadership and the funding cuts, these were some of the key factors that influenced this last cycle of the SNT. And so the minister had, with his strong political leadership and how we were quite pragmatic as a country in the face of the financial crisis, then the continued use of evidence generation and the NMEP, their capacity had improved even more. The partnership with the other with other organizations had improved, and continued with the geospatial modeling, the geospatial analysis, and the mathematical modeling. All of these were the enablers for the SNT implementation. And so these now led to what would influence the new strategic plan. And at the end of the second cycle of the SNT and of the SNT, they also checked the malaria prevalence rate, and that had led to its reduction to 15%. So next slide. So that led to the 15% reduction. So even if, yes, Nigeria carried the highest malaria burden in the world, but that doesn't mean that success was not, or the reduction in the malaria prevalence wasn't ongoing. So for this, we would applaud the country and how it had moved. Next slide, please. But then we'll want to talk about what were some of the enablers and what were some of the barriers and what is our take home and what would be our recommendation for how we sustain this success as we go forward. I'm waiting for the slide. I think the network is slow. So remember that when I started, I had said that the whole process of SNT, the whole framework is divided into 3 main phases. The first phase is how do we gather the evidence? The second phase is how do we use it, and the third phase is how do we act on it? The second phase is how do we act on it? So also very wary of the time. So we had come up with some of the enablers and some of the barriers of each of them. So for the enablers for the first part of SNT, generating the evidence, there was that strong leadership and then the strengthening data infrastructure. But then some of the barriers, sometimes, because as the government, the bureaucratic bottlenecks and fragmented governance also slowed how things were planned and how decisions were made, especially when those trade-offs needed to happen. And then the subnational, their capacity needs to be even more improved. Yes, right now NMVP is doing very well, but we also need to build the capacity of the subnational at the state level even more. And then there are still gaps in surveillance, the quality of the data being gathered, at different levels, with the quality of the surveillance and the integration of the private sector with the data, because we know that in Nigerian currently, a lot of people still go to private clinics. So a lot of our data sets is from the public facilities. But how do we also integrate some of the data sets from the private sector into the wholesome data as a whole for the country? So these are some of the gaps which have already some of these, we started having mitigation plans and have started working towards this integration. I know that in some states, some of the private hospitals send their data in now, but we are not at 100% capacity yet. Yeah, so next slide. For acting on the evidence, one of the key barriers and what we need to improve on is, we know that a lot of the modeling were being done initially by the partners. And so we were asking for sustainability. Let it be done by the government itself, that technical capacity, so that this is housed within Nigeria. And with the way the funding is going and is reducing, daily, this can be done by us, even when there are no funds to fund the consultants who do this. So these have even led to a lot of funding, grants being given to technical partners to even train the government more. We also have limited early engagement. So with some of the subnational actors, and policymakers, is one thing to be a technical person. The way I would present this now, if I was to present this to all technical people who all they do, in the malaria space, I would not break it down this way. But when you're talking to the policymakers, when you're talking to, you need to know how to communicate this in a way that everybody, your audience, understands. So that even understanding of SNT among the subnational actors is still there. And so we need to know how these are where organizations that are in the advocacy and communication sector can come in more and do that advocacy for them and communicate better. And then there are still some political dynamics. I had spoken to some of the enablers earlier when I was going through the different slides, the previous slides. And lastly, next slide, please. This now speaks to how we act on the evidence, and some of the enablers, I had spoken to it, the validation exercises, the alignment of both the government and their partner resources, everybody coming together, that collaboration made things better. But with the barriers, some funding gaps are still there, hence why we had those trade-offs. There's insecurity in some parts of Nigeria, so we also know how that limits the extent of the service delivery that can be offered to people in those geographies. And then limited access. Sometimes we also have now the workforce limitations are even more needed as compared to before. And then we have the insufficient private sector and community engagement, and some of these affect how acceptable these interventions are. For example, when people used to get mosquito nets for when a mother has gone through her antenatal, is given a mosquito net as a source of incentive, can also help her when she gives birth to her baby. But then, are you using it properly? How is that communication flow? Are they sleeping under the mosquito net to prevent the malaria? So this is one thing that awareness and help on this. Um, these were some of the findings that we had. I will pause here because I see that we are at time, but I will pause here to see if we have any questions. Thank you very much.
All right. Thank you very much, Dr. Dachi, for the presentation. It's quite interesting. A lot have gone down the line with Malaria Subnational which is one of the lowest prevalence based on reports was selected as part of our states that were selected for sampling. Then also another question is on school age children, if the epidemiological group
So do you mind turning off your video? It's breaking up a bit, so I can't hear you. And I know I didn't hear some of the questions. And do you mind? I see. Yeah.
Yeah, can we take the questions one at a time? So the first one was from Jessica Quach, which is, did subnational tailoring process identify school-aged children as a distinct epidemiological group or reservoir of infection? If so, how did it implement strategic priorities? Answer that one.
Okay, thank you very much. For school-age children, it did not identify them as a strategic group, but subnational tailoring did influence the vaccines. New intervention that started in, I believe, 2020. The vaccine, we didn't have enough vaccines coming into the country. So we didn't have enough vaccines, but we needed to start giving the malaria vaccine. So national tailoring helped us look at where should these vaccines be given. So we only had, I can't remember but I don't want to say it say the wrong number off the top of my head. But what it did influence was, and it went to the children in Bielsa and Kebbi. Those were the two states initially earmarked for the malaria vaccine and are currently taking the malaria vaccine. But then, as we entered the last malaria strategic plan, we had also expanded to Ondo and Bauchi. So these are the 4 states currently taking the malaria vaccine and subnational, because we don't have enough coming into the country. So it takes the intervention to where it's needed the most for the most impact. So that's how I'll answer your question. Thank you. So if you don't mind with the other question, the second question. Vivian, do you have?
It's okay. Let me, the
Yeah.
first from Bisola Olu B. She says she's curious what informed the choice of representative states, for instance, Borno, which was one of those sampled, and had one of the lowest prevalence rates based on reports from a nationally represented data set. So just repeating again, really what informed the choice of, for instance, Borno State as an example. And we have quite a few other questions.
Okay. Okay. All right. Thank you. So
yeah, thank you.
Yeah. So what informed? So let me just make things clear to be sure that we're not. SNT happened all over Nigeria, but we went to 6 states to gather more, to understand it even more. And so when we were looking at how we selected the 6 states we wanted a representation of the country because we couldn't go to all 36 states, right? So we wanted a representation of all the country, but then there are different factors that influence different things. The selection criteria, for example, we looked at the change in the percentage prevalence between between the last MISs and the NVHS. So in 2021, because the study started in 2025. So the 2025 NMIS, that's National Malaria Indicator Survey, had not been released when we had started. So we were using 2021 and we looked at the NDHS. So we were trying to compare the malaria prevalence in 2018 and 2021. And then we also looked at how are malaria interventions funded. So in looking at it, we looked at Global Fund, we looked at PMI, and we looked at the impact states. How were these states funded? So we wanted to understand, because over the years, is a retrospective study trying to understand what was done in before 2019 up to 2024, from 2015 to 2024. So we wanted to see who were the major funders. So we took states that were global funded states that were funded by Global Fund, states that were funded by PMI, and then we looked at states that were we have funded by the impact, which is a combination of World Bank and Islamic Bank. And then we also looked at, we have 2 states in Nigeria that don't receive any funding. And so we also looked at that state to also understand, because we wanted a mixture. And then lastly, we looked at the geopolitical zone. So based on this, we had selected which states that we went to in the 6 geopolitical states. And Borno, for example, was an impact state, but it had decreased in the malaria prevalence for the areas that were secure. So when they were doing the NMIS, is not everywhere they went because of insecurity, but because of the but based on the areas that were secure, we based on that malaria prevalence. So that's why we looked at Borno State, but they had a 44% reduction in their malaria prevalence from 2018 to 2021. So we had looked at all of those, and I believe it was on one of the slides. Maybe we can share that later, but yeah.
Thanks for that, Adeshi. Okay, we can quickly take a question from Paula. Do you want to unmute yourself and speak, and then we'll take one from Fumi. So, Paul, do you want to unmute yourself to have you here? Hello, Paul, can you hear? Okay, perhaps he can't. Okay, brilliant. You want to ask your question?
I think the admin has to give him permission to speak. He's an attendee.
Okay, so maybe Paul, to drop your question in the chat box. And likewise with
okay, he's in now, yeah.
Yeah, thank you. Thank you very much. Can you hear me?
Yes, please go ahead.
Yes, we can. Yeah.
Yeah, thank you very much. And many thanks for the very, very detailed presentation. So I have 2 questions. So in the presentation, you highlighted that Nigeria's malaria prevalence had fallen from 27% to 15%. I'm curious to know how much of that decline can actually be attributed to subnational tailoring, and what evidence do we have that SNT, or just other malaria interventions or broader changes, is driving the improvement? And the second question, you also mentioned donor fund shrinking. So as this donor funding shrinks, I'm curious to know what specific malaria interventions Nigeria has had to scale back or abandon because of funding constraints, and where are you most concerned that these trade-offs could reverse the progress made? Thank you very much once again.
All right, thank you so much, Paul. Those are very good questions. So, SNT is the basis for all the malaria interventions that are being implemented. So, without in deciding the malaria strategic plan, before the malaria strategic plan is decided upon with all the different interventions, we must go through the SNT process. And it is now a must. That's how it's now being done since 2019. So for the different interventions that have occurred, they were based off of what was done at SNT. They were based off of what was done because of SNT. So that is why we can categorically say that the reduction, the SNT is part of it. Yes, there's service delivery. There's all of the service delivery is these are the interventions, go and deliver these services, go and ensure that this is done. But these decisions were not made without SNT. So SNT is the basis for a lot of these decisions that were made. And that is ensuring, and that's why Nigeria became an exemplar. And that's why Nigeria was picked to let's learn from how Nigeria did. Even if we had the highest burden, but we had reduced and we were on the right track. So based on this, Nigeria was an exemplar, and we were the first country in the amongst the high burden to actually start having that repository. That is really good, and that's what is even in use till date. So that answers your first question. Your second question on the ODA shrinkage, please can you say it again? I know you talked about the ODA shrinkage.
Yeah, thank you. So the question is, as donor funding shrinks, I'm curious to know what specific malaria interventions Nigeria has had to scale back or abandon.
Yes, I remember now. Yeah, so some of the interventions, it may not be in, like, I'll give an example for insecticide treated nets is not for everybody, because one of the things that they look at with the insecticide treated nets is it actually impacting are people using it? So it's also the use of the insecticide treated nets. Then one thing that they had scaled back, and Lagos is in the whole of Nigeria, is the state that has the lowest prevalence. Currently, it sits at 2.6%. And the state with the highest is Ebonyi State with about 31% for the malaria prevalence in the whole country currently, from the National Malaria Indicator Survey done in 2020, released in 2025. So in our latest strategic plan, that has all the interventions that we're going to be using for the next couple of years. And if you look at it as the prevalence reduces, so as the burden gets lower, then it's not every intervention that you need anymore. So I can't speak because you have to speak to 774 because it's now done by local governments. So even in a state, what they're going to give, for example, let's speak Lagos, what they will give in Ekpe is different from what the intervention will be in Alimosho local government, for example. So in the malaria strategic plan, it now contains, so with the ODA shrinkage, what has now changed is the donors have to align with what the country says it needs. So the donors can't say, oh no, I want to do insecticide treated nets, so I'm giving you insecticide treated nets. No, the country says, I need insecticide treated nets for some particular states. If we have these insecticide treated nets and a state you are funding is not one of them, you are not in that state, it's not based on the donor anymore. It's now based on the country's need and how much the donor can provide, or how much finances, because finances is not just from the donor, there's also domestic resource mobilization, but that is not the major source of funding currently. So I don't know if I've helped to answer your question, but the National Malaria Strategic Plan will have all the different interventions for all different local areas in the country. Thank you. So I know that there's a couple more. I don't know how longer we can stay on the call, but I can see the questions now.
Take one from Fumi Ibikunle. She's had her hand up for a while.
Oh, okay. All right. Fumi, can the host give her? Yeah.
Okay. Good afternoon.
Good afternoon.
And thank you so much for this extensive presentation. I would like to start by saying, just to clarify that seasonal malaria chemo prevention is one of the interventions targeted at children, not everybody. Children ages 6 to 59 months, and they are given during seasons of areas that have peak transmission periods that for a few months, like 4 to 5 months. So, and based on subnational tailoring, the states were expanded.
Yes.
So it's meant for children under 5, not for the whole population. But I just wanted to add some things and to say that subnational tailoring is helping the country in determining intervention mixes, because there are a lot of interventions that different aspects of the malaria cycle or parasite cycle. Some are targeted at case management, prevention. Under that, we have SMC, we have the perennial malaria chemo prevention that will soon become a policy adoption for the country. Other than we have the intermittent preventive treatment for pregnant women. And then there's also what we call the intermittent preventive treatment for school-age children, because they are also like a reservoir, and research has shown that if you could reduce the body within them, you could see an impact in children under the age of 5. So that's also an intervention, but it's not yet been deployed in the country. So subnational tailoring helps the country in modeling which intervention combination, when we do it in a particular environment, can help reduce malaria burden. And when there are new interventions being added, for example, like the malaria vaccine, it helps us to determine which location it could go. And as noted, this intervention mixes are done at the states and also up to the LGA level. So in a state, you could see that some LGAs are selected for malaria vaccination while some are not. And then when you look at the map, what they've been doing with the intervention and subnational modeling, because at national, they're supposed to develop scenarios and test it. And then say, for this state, do this. If you look at all the maps you show, they've helped to show if you do this set of interventions here, you reduce burden. But if you look at the maps, one key thing that keeps changing, more importantly, is either the addition of a new intervention to the mix or changing of the type of net to be used in a particular locality. And this is based on data. So most times these models are being incorporated, being done by WHO and NMEP and some partners, and say these are the intervention mixes you need to implement in your state and local government at highest coverage, and we could see a reduction. An example of impact of subnational tailoring is what we see in Kebbi. Kebbi, as at 2021 malaria indicator survey, had the highest burden. But because of the intervention mixes, introduction of malaria vaccine, their burden has dropped significantly to 18%. And that's a show that if we combine these interventions, you don't need to do all, but there are some selected interventions that are very good for your environment that would decrease the malaria burden. And most times when these intervention mixes are done or released, they are done in tandem with when the National Malaria Strategic Plan are being released. But one thing that you mentioned that I just wanted to reiterate is that like national have the capacity to do the intervention mixes and release to the states. The state needs to now understand their health system structures and see how they can leverage government funding and plow into the annual operational planning process to be able to get government funding in addition to donor funding. Like you said, donor funding is reducing, but they need to start getting into the government funding to support implementation of these interventions, looking at where do I have my strength? Do I have my strength in the health facilities? Do I have my strength in the community? Do I need to do more community outreaches to reach these different targeted groups? ITN Net, do I need to
sorry for me to break you in. Apologies for that. We're already very, very short time.
Okay, just to add one more thing. That in terms of private sector, it's not just only the private health facilities, but looking at also at manufacturers. And with this new minister talking about swap, there's already a lot of with PVAC working with manufacturers in the country, making sure some of these commodities, especially ACTs, are being produced in the country.
Thank you very much for that. We have recently put a factory in other things. So we can probably have 10 minutes, and then we will close at 4 just to respect people's time. So we have two more questions from Farouk and Olubenga, and then Solomon, and actually we can close on those two. Thank you very much.
Okay.
Thank you very much, Vivian. Dr. Dachi, we go this way because of time. If you can respond to some of the questions that are still open on the screen.
So what I will do is I'll respond in the chat, the ones that's typed, so that I respond
Farouk.
In what this evidence can really help us do in suppressing the malaria burden. So my question would be, how much are we thinking about carrying stakeholders along, especially the subnational government, looking at the misconception that can easily spring up from you are giving A, you are not giving B this intervention. And that is the lens I would like to also get from this conversation. How much are we going to leverage on carrying the critical stakeholders, the locals along, so that people accept this inherently? Thank you, and over.
Thank you, Farouk, and which was one of the things that we spoke to earlier regarding some of the recommendations we had made based on the research we had done. Some of the recommendations was on communication and early engagement. So also explaining to some of those stakeholders at the subnational level, and sometimes the program managers at the subnational level understand, but because the people are used to maybe getting SMC and then you don't see anymore, or you don't need the ITNs anymore, that's insecticide treated nets, there might be some backlash, like you rightly said. So it's all about advocacy. And I know that the NMEP work with some of the some community-based organizations to help with that messaging and creating that awareness so that the acceptability, but it needs to be better, and advocacy and communication needs to be better at the national level, at the subnational level, at the community level. It needs to be improved. So these are some of those, and that would help dispel some of the rumors. Some people, when you give them SMC or you give them the vaccine, they're saying they don't want it or they're not accepting it. These are some of that demand generation and some of those awareness that needs to be created, and advocacy and communication will help improve on that. They have started, but it is not where we need to be, but it can be improved. So those are some of the recommendations that came out from this research. Prof. Okuru. And just to also mention that Prof. Mokulu was very, very instrumental in this research. I would never forget our first meeting when he also had to explain what SNT was and all of this. So it's lovely to have you here. So Prof, over to you, sir.
Thank you very much, Dr. Dachi. I'll just take 1 minute or two because of our time. So I have followed carefully, and I just wanted to underscore for the benefit of some of our participants here that SNT remains a strategy of delivery of the various interventions. So SNT is not an intervention, but a strategy of delivering the intervention that matches the distribution of malaria in the country, which progressively is becoming increasingly heterogeneous. And therefore, SNT the 2025 has been quite fundamental in how things are shaped in the current national malaria strategic plan. So that's something just for us to understand. And I wanted to ask, do we have any intention of maybe looking at cost savings that are attributable to SNT? The fact that we become targeted, we live in a situation where we are like what that happened with SNT and without SNT. I think that will be something that helps the communication as we continue to push it downwards. But thank you very much for the
Thank you, Dr. Okolo, and thank you for your support during the research as well. What's for you for Dr. Prof's question, and we go on. Thank you.
Yes, so some of the, like I mentioned, with the ODA shrinkage, SNC has also helped with how we use it. And Prof just alluded to this, with his last comment. How we use SNC in a way that it helps, but I would say we put interventions where it's needed. So rather than spreading it across, and then you can move interventions to where you need it. In a place where you don't need it, you can take it from there to point A, and point A doesn't need insecticide treated nets anymore. Point B needs it. So rather than, because point A needs to have it, you can just, point A used to have it, but they don't need it anymore. You can move that and save the cost in point A and move it to point B. So these are also ways of us making SNC ensuring that our resources are better used. So just to highlight what Prof. Mokulu said. And up on our website, Nigeria Health Watch, and I know that before this virtual briefing, we had shared some highlights, and we had shared a research brief, and then we had also shared a key fact sheet that we had developed and used for the World Malaria Day in collaboration with the NMEP. We had shared that with the different participants from the media, but we also have some of these on our website. So I know there are a lot of questions regarding where you can get a lot of things. We will also point those out to you on our website in resources, so you can go there and get some of this information. So I think that will be it for the rest of the questions I would continue to answer. But Solomon, over to you and Chibike for the.
Thank you very much, Dr. J. And going on the lighting our director of media program and watch, Mr. Chibike, also to give his remarks and thanks. Over to you, Chibike.
Thanks, Solomon. Thanks, Adachi, for that excellent presentation and also engaging with our participants. Special thanks to everyone that joined and stayed, give us extra 30 minutes of their time. Really appreciate that. So my task is very straightforward, really. Just to essentially thank us and speak to. So for me, as the director of media programs and the rest of the comms team, our constituency is the media. Of course, we work with other stakeholders. I know here, like Prof that ask questions and other colleagues who work in the space. But essentially, like you mentioned at the beginning, what do we want, out of this for the next steps of this, especially as we are counting down to what Mosquito Day in the next 2 days. So the big question is what next after now? How do we take these conversations forward? Especially for colleagues who are journalists in the room, who are editors in the room, what sorts of stories can you commission? What sorts of questions can we continue asking in addition to some of those that have been asked here, right? Some of those were in those documents that Adachi mentioned, the brief that we shared, but this just highlighted a few things that sort of came up from the discussions that has happened. Why is Nigeria an exemplar? So those are questions that we can now explore further and continue to unpack. The vector side of things also came up, especially leading up to what area. There's also an accountability question. So the data is saying this is where we should be headed. So who is not going there? Who is going on the reverse side? Who is going reverse, right? The other way around. So those are questions that we can start asking. How much are we even aligning with the insights from the SNT? Who owns the analysis? All of this came out from that report, right? Then the private sector blind spots. So we're happy to help you make these connections, share access to stakeholders, Nigerian team members who are part of the research, other technical partners who support edits. And we're happy to connect you with all of these people so you can schedule interviews, more in-depth conversations with them and get better understanding to inform your stories or other content that you might want to put up. But even beyond the journalists and media and colleagues in the room, it's essentially for all of us, right, to start asking these questions. How are we? Because malaria is something we talk about every day, like the context that the team gave at the beginning. So if there is data saying this is where we should be heading, right? The question now is why are we not doing that? Are we doing that enough? In terms of the money we are investing, the strategies that we are adopting. So we're happy to help make these connections. Even the sort of breakdown of happy to send the chat, send an email to us for Nigeria. We're happy to help you share these resources, with sources that we can have conversations with. You and appreciate your time. It's with us.
Very much, Chibike, and thank you very much to all of our participants. We hope that you take resources from here to enhance your work. And for the journalists on the call, we hope that you're able to spotlight this and put in more attention to the malaria subnational tailoring in Nigeria. Thank you very much. And this will be the end of the virtual briefing. Thank you.
Bye, everyone.